So welcome to our training webinar. My name is James Borders, and I'll be moderating our event. All right, so before we begin, I'll briefly discuss logistics for the webinar, provide introductions, and then we'll proceed into the tutorial on VASES with additional time for practicing interpretation. So this webinar is being audio and video recorded to be uploaded at a later date for free public viewing. So we hope this serves as a free resource for VASES interpretation with VASES. As I'm sure you've noticed, we're live streaming this webinar on YouTube, so feel free to post questions in the chat. We'll do our best to answer questions during and after the webinar, but this may depend on time restraints and the amount of questions we receive. Resources for VASES, such as published manuscripts, unofficial rating sheets, and additional training materials are publicly available on our professional websites and the Open Science Framework. You can also follow us on social media for periodic updates related to VASES. So like I said earlier, my name is James Borders. I'm a PhD student in the Laboratory for the Study of Upper Airway Dysfunction at Columbia University. I'm also a speech pathologist with prior experience working clinically in inpatient and outpatient roles. My research focuses on evaluating and treating cough and swallowing dysfunction with additional interests in metascience and statistics. So next, I'll hand it over to Dr. Curtis.
Right. Thanks, James, and hello, everybody. So my name is also James. There are two Jameses here, but I'm James Curtis. I'm a postdoctoral research fellow in Dr. Michelle Troche's Laboratory for the Study of Upper Airway Dysfunction, which is at Teachers College, Columbia University in New York City, which is also where I completed my PhD. And just a quick little bit of background about me. I'm also a speech language pathologist. I'm an adjunct assistant professor here at Columbia and a board certified specialist in swallowing and swallowing disorders. And prior to completing my PhD, I worked clinically in the Department of Otolaryngology Head and Neck Surgery as an outpatient speech pathologist, where much of my weekly caseload involved endoscopic assessments of voice and swallowing, including fees and stroboscopy, as well as video fluoroscopy of video fluoroscopic assessments of swallowing. So that's kind of the lens at where I come at with a lot of my research and the research that we will be presenting today. And my research interests include performance and interpretation of fees, respiratory swallow coordination and its effects of training on swallowing in people with neurologic diseases, and assessing how principles of motor learning translate to cough and swallowing rehab. Like I said, we are located in New York City, so I apologize in advance if there's like ambulances and lots of noise. That's comes with living in the city, I guess. All right. VASES was developed as a collaborative project in the Upper Airway Dysfunction Lab at Columbia in New York. So other people that I'd like to acknowledge and thank and introduce to all of you, but who aren't necessarily involved with this webinar, are my colleagues, friends, and mentors who are part of developing VASES. So this, of course, includes James Borders, who you all just met, will be moderating the session. He'll be seeing the questions in the chat. I actually won't be because I kept getting feedback, so I'm not seeing YouTube at all right now. So he'll be the one looking at the questions and then sending them my way. We also have Avery Dakin, who's a speech pathologist, and she's currently doing her PhD also with us in the Upper Airway Dysfunction Lab. We have Seikaly, who did her master's degree at Columbia and her clinical fellowship with us in the lab and is now a practicing clinician in California. Dr. Sarah Perry, she completed her postdoc in our lab and is now a research scientist and clinician in New Zealand. And then of course, Dr. Michelle Troche, who's the director and PI of this lab and is an incredible mentor. So thank you to all of them. We'd also like to acknowledge and thank all of you for being interested in VASES and attending this webinar. James Borders and myself are so thrilled that there has been so much enthusiasm about rating fees using VASES, and excited to see that we had so many registrants. We were anticipating doing this webinar with like 20 people and doing it via Zoom and having a kind of face-to-face meeting, but far more interest than I think we were originally expecting. So in fact, here's a map representing the geographic locations of all the registrants for this webinar. And so this includes about 1,100 registrants from 48 different countries listed here. So I think that's pretty incredible. Okay, so enough with the introductions. Let's kind of talk a little bit about the background of VASES and the rationale for why it was developed, and therefore a rationale as to why you might want to use it in your clinical practice. So as most of you all, I'm sure, are very well aware, flexible endoscopic evaluations of swallowing, or FEES, it's an invaluable procedure that was originally developed by the brilliant Dr. Susan Langmore, used to assess swallowing in people with known or suspected dysphagia. FEES has been shown to facilitate pretty high sensitivity and for visualizing functional swallowing outcomes, specifically pharyngeal residue, penetration, and aspiration, making that one of the main reasons many clinicians use FEES to evaluate swallowing. But there are some limitations. Several rating scales have been previously developed to help standardize how we rate the amount of pharyngeal residue and penetration that we are seeing during FEES. This is a good thing, but there's a decent amount of variability, ambiguity, and inconsistencies across these different scales that have been developed. So these rating scales vary in terms of how they go about rating residue and penetration. For example, some scales describe residue relative to a patient's anatomy. We call this an anatomically defined scale. Whereas other scales estimate the amount of bolus that is cleared through the pharynx without specific regard to anatomy. So did all of the bolus clear through the pharynx, or did 90% of it clear through, but 10% of it's remaining? And so we call this a bolus clearance estimation method. Most of the scales that have been published are anatomically defined scales, but they vary in terms of the number of severity categories. So the scales that are out there, to my knowledge, are all categorically based scales, meaning we say, oh, they've got a mild amount of residue, or a moderate amount, or a severe or maximal amount. Some of the scales have 3 categories, such as none, mild, maximal. Others have 4 to 5 categories, such as none, trace, mild, moderate, maximal. Others have, I've seen 7 categories. Furthermore, some scales use the same severity category labels, but differing definitions for those same labels. So if we just even think about the term mild pharyngeal residue, we can see differences in how that's described across different scales, where a mild amount of pharyngeal residue might mean less than 10% of bolus remaining. It could mean 5 to 25% of a structure being filled, less than 33% of a structure being filled, or less than 50% of a structure being filled. So there's a lot of variability across these scales regarding, in this example, what mild amount of residue actually means. And so you can imagine if different people are using different scales, but using the same terms, that it could potentially negatively affect how reliable we are with each other unknowingly. And this is not necessarily a good thing for evaluation or treatment planning. Furthermore, at least to my knowledge, there aren't any scales, or certainly widely used scales, which describe the amount of aspiration that we are seeing on an exam. Certainly we have scales like the PAS, the penetration aspiration scale, which describes the presence of and reaction to aspiration, but no kind of clear way to describe literally how much aspiration we are seeing. And I think quantifying this is really important. Working with people who have degenerative diseases or very chronic conditions, we don't necessarily always expect to cure or fix someone's dysphagia, right? We don't expect maybe aspiration to go away completely. But I think one really important indicator of improvement from therapy is maybe they're aspirating the same amount or the same frequency, but it goes from being a lot of aspiration to very little bit of aspiration. And I think we needed a way to try to quantify that and qualify that. Lastly, while many scales describe anatomic and temporal landmarks used to rate residue, penetration, and aspiration, I would argue that there's been how we actually go about identifying these structures is a little bit challenging and hasn't been really clearly defined across scales. Some scales might talk about molecular residue or piriform residue, but literally how do we define where the molecula starts and stops, like looking at pixels on a computer? How do we draw that line specifically? And to my knowledge, there hasn't been anything that detailed before, which could certainly negatively affect reliability with ourselves, with our colleagues, and therefore how research findings generalize to the patients that we're seeing. So we identified that there was a need to kind of continue to improve the standardization of VASES interpretation. Certainly there have been strides in the past, and we kind of wanted to build on that to further improve standardization of VASES interpretation by establishing clearly defined anatomic and temporal boundaries within which to rate pharyngeal residue, penetration, and aspiration. And so this led us to the development of the visual analysis of swallowing efficiency and safety, or what we call VASES, which was originally published in Dysphagia earlier this year. So VASES is not a dysphagia severity scale per se. Instead, it's a standardized method used to interpret VASES. In other words, the intent of VASES is to get everyone on the same page, to make sure that we are all looking at the same things at the same times and rating functional swallowing outcomes using the same method. So for example, if I said I was judging the amount of residue contained within the oral pharynx, you would know exactly what I'm looking at, where I'm looking at, and when I'm looking at it, and how exactly I'm rating it, right? So that's the idea with VASES. So it's kind of a standardized framework within which we interpret these. VASES involves 4 larger primary concepts using standardized VASES interpretation, which include the what, how, where, and when of rating. VASES also includes some smaller kind of secondary rules. So all of these concepts and secondary rules are described in detail in the original VASES manuscript, which can be found on the publisher's website, Dysphagia, or for free as legal self-archive versions on the professional websites of both myself and James Borders. So together, these 4 concepts and secondary rules were developed with the intent of improving the transparency, reliability, and sensitivity of VASES interpretation, which is very important for clinical purposes. And elements of VASES are also intended to line up a little bit more with video fluoroscopy with the intent of trying to enhance generalizability between exams. So with all that being said, let's dive a little deeper into VASES and gain some practice rating some endoscopic images. So first, the what. The first concept of VASES is what. And so the what of VASES outlines the actual outcome measures used to interpret swallow function at the individual swallow trial level. And so there are 7 outcomes that the original VASES manuscript describes. There could be more in the future, but the current manuscript outlines 7 outcome measures using VASES. So these outcome measures include 6 different residue ratings. The residue ratings include the amount of residue filling the oral pharynx and filling the hypopharynx, and then also covering the epiglottis, laryngeal vestibule, vocal folds, and subglottis. Residue ratings are made separately for each of these 6 anatomic landmarks because they are intended to capture swallowing efficiency, meaning pharyngeal residue, and then separately swallowing safety, meaning penetration and also aspiration. VASES also includes a standardized method to score the penetration aspiration scale, or the PAS, which is a popular scale used in both clinical and research practices to describe the depth of and reaction to airway invasion. So those are our 7 different outcome measures using VASES. And so the idea is that we would look at a swallow and then for that one swallow, provide 7 different ratings, which on average takes about 1 minute to do. So the second concept is the how. So we just talked about the what, and now we'll talk about the how of VASES. The how of VASES outlines how we actually go about providing these residue ratings and PAS scores. So for VASES, we chose to adopt an anatomically defined residue rating method. This means that we are indicating how much residue is present relative to the patient's anatomy. For example, we might say that 25% of the oral pharynx or vallecula is filled with residue, or perhaps 10% of the laryngeal vestibule is covered with residue. This is different from that bolus clearance method that I mentioned earlier. And we use this anatomically defined method, given some of the recent surveys by Dr. Pesena, Langmore, and Kimoli, who have found that the majority of clinicians most of the time are already rating fees using this anatomically defined method. For VASES, we also adopted the use of 100-point scales to describe the amount of residue filling or covering these 6 different anatomic landmarks. So VASES was originally published using 100-point visual analog scales. So for those of you less familiar with visual analog scales, the way they were originally developed would be a pen and paper task. Someone would have a piece of paper, they'd have a 100-millimeter line, and someone would place a tick mark on that line to describe how severe a measure was. And then you measure in millimeters how far that tick mark is from that leftmost point. So it goes from 0 to 100. If I placed a tick mark here, that might be about 13 millimeters. So they would have a score of 13 out of 100. And that's how visual analog scales were originally developed. And they are kind of being implemented into digital format. So you don't have to use a pen and paper and ruler, but it's still not super accessible. So for VASES, this visual analog scale included on the leftmost point 0%, indicating 0% of an anatomic structure had filling or covering, or a structure had 100% filling or 100% covering. So these are not severity impressions per se, but instead, what we're doing is trying to provide an objective estimation of just how much residue is filling or covering a structure without considering how severe or dangerous it looks. I think it's important to note that we chose to use this 100-point rating system based off of some really amazing research by Dr. Jessica Pesena and some of her colleagues at Boston University, which through these collection of studies have consistently found that these 100-point scales, I believe all of them were visual analog scales, consistently found people to be more reliable than using categorical scales, meaning us saying mild, moderate, and maximal. And they're more sensitive to detecting smaller changes over time. And that's really important clinically. If we are treating a patient or we're monitoring them over time, we want to be able to detect changes over time. So again, it kind of goes back to the aspiration example. If we see someone and we give them 3 different trials of 20 milliliters of liquid, and on average, they're aspirating about 40% of the sublethal shelf being covered with aspirate residue. We want to be able to track that over time and see, oh, maybe they're still aspirating, but that aspiration is going from 40% down to 30%, down to 20%, right? So we want to be able to track some of those smaller changes that could be missed with larger categorical scales. We've recently submitted a study, which is currently under review, which in part looked at the validity of using numerical ratings as a potential substitute for visual analog scales. So what I mean by this is instead of using a visual analog scale where we have to draw something out, rate a tick mark, or somehow create some sort of digital visual analog scale, we asked ourselves, could we simply just say 25%? So if I'm looking at the vallecula and I think 25% of it's full, do I have to use a visual analog scale, or could I just type in 25 to indicate 25%? And our data would suggest very strongly, in fact, that yes, this is actually a pretty valid substitute. Of course, we still need to wait for it to get published in case there are any other review comments, but this seems to be a valid substitute. So we'll of course make an announcement on Twitter if this does get published, so stay on the lookout for that. But I suspect that for most people, most of the time, these numerical ratings would be much more feasible to use in clinical practice. And in fact, when we do some ratings later today, that's the method that we'll be using. Okay, so we talked about the what, we talked about the how, now we have the when of VASES, the third of the 4 major concepts. So the when describes our temporal markers for VASES. So for this, VASES outlines clearly defined temporal boundaries or timing markers. So these are used to guide when pharyngeal, laryngeal, and subglottic residue is rated, and it's used to judge when airway invasion occurs. So these temporal boundaries include before the swallow, during the swallow, after the swallow, and between bolus trials.
Chin up. Now you.
So these temporal boundaries, as I mentioned, include before, during, and after the swallow, and also between bolus trials. And these are meant to line up with some of the temporal boundaries that are often used with video fluoroscopy to try to enhance our generalizability. For VASES, we try to capture residue that's present after the swallow. So that means what we're seeing after the swallow, or maybe between bolus trials if not much has changed, that's what we're using to describe the amount of residue that we're seeing. We also look at penetration aspiration scale scores, the PAS, for each of these 4 different temporal markers. And then the way we've recommended doing is reporting the worst PAS across those 4 boundaries. Of course, that could be adjusted if you'd like, but that's what we currently suggest. There you go. Then we get to the last major concept, which is the where. So for time's sake for this webinar, we'll practice VASES interpretation using where and how to rate still endoscopic images. So the where of VASES involves clearly defined anatomic boundaries for these 6 different anatomic landmarks, which we've discussed, which include the oropharynx, hypopharynx, epiglottis, vestibule, vocal folds, and subglottis. Residue ratings across these structures are intended to measure the impairments related to swallowing efficiency, so pharyngeal residue, and also swallowing safety, so penetration and aspiration, thus the name of VASES. So let's get started with actual practice now. So the first thing we want to practice is looking at our anatomic boundary for the oropharynx. So how do we actually define the oropharynx? Well, the first thing that we do is try to identify the 2 points where the area epiglottic folds merge into the epiglottis. So 1 point for the right area epiglottic fold and 1 point for the left area epiglottic fold. So at what points do we get merging of the fold into the epiglottis? And so things that we recommend is to locate where the vertical edge of the epiglottic fold is either no longer visible, or kind of look at this black shadow, how it's a single line, and then look at the point where it kind of trifurcates, essentially. So that would be the point then where the area epiglottic folds merge into the epiglottis. Once we identify those 2 points, we draw a line. This is an imaginary line. It's just on here so you all can see it, but it's just with your eyes. You're drawing a line that connects those 2 points, extending across the entire viewing monitor. Then everything above that, anterior and superior to that line, but not contained within the laryngeal vestibule, is defined as the oropharynx. Within the oropharynx, we have the vallecula. So the vallecula is contained within the oropharynx, and it's defined as the space extending horizontally from the rim of the epiglottis, which is where the lingual and laryngeal surfaces meet. I think the rim of the epiglottis has different definitions across different clinicians and researchers, but that's how we define it. Horizontally across to the base of the tongue, which we see here. So that's how we draw our boundaries for the oropharynx and specifically the vallecula as well. So then how do we rate oropharyngeal residue? First, we identify all the residues seen throughout the oropharynx. Okay, so we're trying to capture residue that's seen anywhere in the oropharynx, not just the vallecula. Then we ask ourselves, how full would the vallecula be if all of the oropharyngeal residue was contained within there? So there's going to be some guessing and some estimations going on. We kind of pretend to scoop everything into the vallecula, and we estimate how full is the vallecula with oropharyngeal residue. So that's the question that I ask in my head when I'm providing this rating. So to do this, we want to try to estimate, first of all, what's the vallecular size at its largest? Ideally, we get a nice image of that at some point during our evaluation so we can get a really good concept of how big is that vallecula. Because we know if the base of the tongue is retracting and hipping the epiglottis, the vallecula is going to be super small. And so we know our perception of residue is going to change drastically based off of what we call the housing space. So we want to try to standardize that by thinking about when the vallecula is at its largest, how full would this residue be? Okay, so you're kind of conceptualizing when would the vallecula be its largest, and then how full is the vallecula with all of the oropharyngeal residue. So imagine relocating all of the residue into that maximal vallecular space. For liquids, most of the residue is already going to be contained within the vallecula. So there's probably not too much imaginary scooping that you're doing. But for things like semi-solids or solids or maybe very thick liquids, the residue could be contained outside of the vallecula. So kind of higher up on the base of the tongue, along the lateral pharyngeal walls. And so you're going to put that all in the vallecula in your head. Then you provide a number that should range from 0 to 100. So you're saying 0% of the vallecula is filled with oropharyngeal residue, or I think 10% of it's full with oropharyngeal residue, or 15% of it's full with oropharyngeal residue. And then just as a couple of side notes, two-dimensional coating, certain types of colorants like barium or heavily concentrated white dyed water has the potential to really kind of coat a lot of these structures. For the oropharynx and the hypopharynx, we don't want to put too much weight on the coating. Certainly there's something there, but it's not actually filling up that three-dimensional space, okay? So if it's just two-dimensional coating, it doesn't look like there's any sort of pooling effect happening, then that should be rated as anywhere from greater than 0, because there's something there, so we have to document that, but it's probably less than or equal to 3%. And we need to develop a better understanding of kind of where that cutoff is. We recommend 3% at this point, though. This is again based off of some other research by Dr. Jessica Pesena, where 3 kind of descriptively looks like it might kind of be some sort of threshold for none or trace. So that's kind of why we selected that. But regardless, it should just be on the way low end of our scaling. Three-dimensional pooling can range anywhere from 0 to 100. So even if it's not coating and it's a little drop, that little drop could be 1%. It could be 2%, 3%. So that 1 to 3% isn't reserved just for coating. It could also include pooling if it's a super small amount. So if we have this image here and we were judging the white stuff, the first thing you should do is try to identify where the oropharynx is. So I would look at this point here, this point here. I would draw an imaginary line. And then I'm looking at all of this kind of white little trace coating lines, right? So what I'd like you all to do is in your head, think of a number ranging from 0 to 100. You can type it in the chat. Sorry, James Borders, I don't know if that's going to get crazy. And think how full is the oropharynx, how full is the vallecula with oropharyngeal residue? I'll give you like 3 seconds to think about that while I take a sip of coffee. Great. I hope you all said like 1 to 3%. I would say 1% with this. It's like there's practically nothing there. We see something, so we have to document that. It's not actual pooling. We're not talking about coating across structures. We just see a little bit of, we're not talking about pooling up. We're just seeing a little bit of coating. And so that's in that, it's not really filling up that three-dimensional range. So I would probably put this as 1. 1% of the vallecula is filled with oropharyngeal residue. We have this example here, which maybe looks a little bit more extreme. So here, how full is the vallecula with oropharyngeal residue? So we have our boundary. We're maybe losing a little bit of visualization of where those 2 points are, but we could draw a line, and we're essentially looking at all of this stuff. And so here, how full that three-dimensional space is full with oropharyngeal residue. And I think you go a couple of ways with this. In my head, when I originally looked at this image, I thought this was all two-dimensional coating. So if I thought that was actually true, and this could be a little bit of a reliability issue, but if I thought it was all two-dimensional coating, I would probably score this a 3. Mostly all of the mucosa is covered, but it's not actually filling anything up. There's a lot of room still in the vallecula. So I would say 3% of the vallecula is filled with oropharyngeal residue. And I think an image like this shocks a lot of people who are newer to VASES or maybe just newer to VASES interpretation. Because it's very striking to the eye, but functionally it's not actually filling up that three-dimensional space. If someone said more than 3%, I'm suspecting that what they're doing is they're thinking this is actually pooling up, and then maybe this stuff right here is pooling up. And if that's the case, I could buy a higher number. I could buy maybe something like, honestly, something like 10%, right? So if I said 10%, it's because I'm thinking that this is, three-dimensional pooling. And so if I multiplied that by 10, the oral pharynx would be completely full, right? Because it's 10%. So if we have 10 of those, the vallecula would be completely full with oral pharyngeal residue. The intent of this image is to show two-dimensional coding. I would give this a score of 3. Here we have maybe a slightly more straightforward image. So here, how full is a vallecula with oral pharyngeal residue? And we're judging the green stuff. So we might see a little bit of green here, maybe a little bit here. So we're thinking about our boundary. We're scooping all the oral pharyngeal residue into that vallecula, which would be kind of here. All right. So I'm going to give you 10 seconds to think about this. Maybe put it in the chat, or if you're at this webinar with colleagues or friends or something, maybe just say it aloud to them. What number would you give this? And I'll take you through kind of my thought process here. So typically what I do is I think of a number, and then I kind of cross-check myself. I try to like keep myself in check a little bit. And to do that, what I say is, let's say I thought this was a certain number. I would say, if I thought this number was, let's say, 50%, let's say, I don't think it's 50%, but if I thought it was 50%, then what I'm saying is, oh, if I multiplied that by 2, if I have two 50%, that's going to equal 100%. So if I doubled that amount, would the vallecula be completely full? I don't think it would be nearly completely full. If I quadrupled that amount, would it be completely full? That would be a rating of 25%. I don't think it's 25%. If I had 10 of those, would it be completely full? I think I could start to buy 10%. I think it might be a little bit less. So in my head, I'm actually kind of going between 5 and 10% right now. And because I am not a perfectionist and I like to hedge my bets, I would probably go halfway in between and say 7, right? So I'm like, I don't know, it's like 5 to 10, so let me just say 7. And that's where I'd call it. And I think this is a good example of the difference between using 100-point scales versus categorical scales. So for some scales, if we said 5%, that would be considered trace. And if we said 7%, it's considered mild, or 5 being trace and 10% is mild. And so we're getting drastically different categories, even though we're really only off by a few percent, right? And so I think this is one kind of nice advantage of using 100-point scales. So thank you, Dr. Pasania. That was brilliant. So hopefully you and your colleagues were, somewhere in the 5 to 10 range. I think 15% isn't too far off. Probably I wouldn't go there. 20% I think is probably too high, but hopefully we'll start to kind of calibrate our eyes a little bit. I should mention too that I've recently thought about, I'll mention this at the end, never mind. I'll keep you on your toes. All right, 2 more images for the oral pharynx. So how full is the vallecula with oral pharyngeal residue? That's the question that you're asking yourself. So the first thing you got to do is try to identify the anatomic boundary. This is a still image, so ideally you would have gotten kind of further in and been able to identify your points. Oops, here's my mouse. So with all of this here, how full is, with what we are seeing, there could be stuff higher up. How full is the vallecula with oral pharyngeal residue? So either in the chat or with your colleagues and friends or just to yourself, I want you to actually say or type an actual number. So ranging from 0 to 100, how full is that vallecula? Is it 5% full, 10% full, 30% full, 50% full? I'll give you 10 seconds and I'll kind of walk you through my thought process.
And then James, once you're done walking through your thought process, we had a great question that I think applies to this case.
This example here, I've got one more image after that. Do you want me to do it after here or for
the? Talk about it once you're done with the landmark.
Okay, all right. Whatever you think, I'll do whatever you want. Okay, so first of all, as I walk you through my thought processes, I'm just trying to give you things to chew on or think about. It's not that my eye is so much better than anyone else's. In fact, I could very well be off. But the idea is that we're going from being very not standardized to being much more standardized. So in my head, when I'm looking at this image, what I see is, oh, the left seems to be higher up than the right, right? This looks to be kind of settled down a little bit more. If I'm looking at just the left, I'm thinking it looks like it's maybe up about halfway, maybe a little bit less. This is much lower. So I'm thinking about the height in terms of it reaching the rim of the epiglottis. And I'm also thinking about how far is it from the base of the tongue. So there's kind of like a pyramid to this, right? It's not just length across the epiglottis. So if I was to first look at this, I could see people maybe giving this a 50% initially. But hopefully then you realize, oh, this side is less than this side. So maybe that drops it down to about 40% or 30%. And then we actually have all of this space over here that's not at all filled. And so that brings me down a little bit more to like, I don't know, 25%, maybe I could see 20 to 30% for this. So I would probably hedge my bets again and say 25%. So I then check myself, keep myself in check. And I say, okay, I'm saying 25%. So that means if I quadruple this amount, the vallecula would be full. And I think, yeah, we'd be pretty close. We might not be 100% right, but I think we'd be pretty close. 20%, I think could be pretty good too. And now that I'm doing that method, I don't know if I would buy 30%. I think if we tripled this amount, I'm not sure the vallecula would be completely full. So I'm glad I did that method. So that would bring me down to like 20 to 25%. So then I'll say 22%, honestly. And then James, I'll do this last image before then getting to that question. So then we have an image like this. So how full is the vallecula with oral pharyngeal residue? So go ahead and type that in the chat, say it aloud to yourself, or say it aloud to your friends and colleagues. I'll give you 10 seconds. I'm also going to eat a little bit of a scone. I hope you all don't mind. All right. So I'll tell you what, with this image, I originally thought this was like about 100%. I've given a few in-services on VASES and calibration and whatnot, and I get lots of 80% for this. And so I think that was my bad. In my head, when I'm thinking about how full is the vallecula with oral pharyngeal residue, I'm seeing all of, this blue stuff fill up to the rim. And so I thought 100%, but we have a little bit of the shadowing here, which could indicate that it's not actually full completely. And it looks like there's actually some space kind of down here to the base of tongue region. So I do actually think it's probably closer to like 85 to 90% is what I would think. I still think 80% is on a slightly lower side. I'd probably do more like 90%. But that's kind of my thought process is it looks like it's essentially up to the rim. Oh, there's a little bit of shadowing, which could indicate some space. It looks like there's a little bit of space over here. But then we have all this other oral pharyngeal stuff, which if I scooped it, might bring it up a little bit higher. So whatever, 90%-ish. Someone might say 95, someone might say 85. That's a lot regardless. Okay, James Borders, what is the question? And if I get stumped, will you help me out? Will you help me?
Yeah, of course.
Okay.
Okay, so a couple questions there's definitely a theme in the chat. First, can you kind of speak to whether VASES is whether when you rate with the visual analog scale, if it's referring to the bolus or the anatomic landmark?
So it should be, all of our residue ratings with VASES should be an anatomically defined residue rating scale, meaning we need the residue to be filling it up, right? And so in this example, it's in we're looking at the amount of residue that's filling up a space, and we're saying how full is that space because of this residue. Does that kind of make sense? So how full in these examples and in the airway it's going to be covering is that structure with residue. So it's kind of a combo, but it's the anatomically defined methods for residue ratings.
Perfect. So I think another question that's come up is, what do you do in cases where the area is not completely visualized? So I think Dr. Plowman gave the first example with white liquid. So when you don't really know what the denominator is of that fraction that you're estimating.
Wait, so if okay, yeah, so like for instance, if we're only seeing like the left side versus the right side, or we're an example like that, like where maybe the camera got gunked and so like we're only getting partial visualization.
Yeah, if you can't visualize the whole structure.
Yeah, so do you remember the answer to that? We actually specify that in the VASES manuscripts. That might be one of the secondary rules. And I don't remember offhand. I believe that I believe that in the manuscript we said, like, if we don't get an image on the opposite side, we assume it's the same on both sides. But we never, this is another rule, is we never make inferences about residues. Like if we were judging, I think a clear example might be like the subglottis, right? So maybe we're seeing like one half of the subglottis, but we're not getting like another half that's underneath one of the vocal folds. We never make assumptions about if residue is actually there or not. So, so it sounds like I actually just contradicted myself. So it might change by structure. Do you remember if we talked about that in the secondary rules? Because I know we've discussed that and we wrote it down somewhere. It might be in like the supplemental document.
Yeah, I'll look it up.
Okay, yeah. Definitely one of the secondary rules is we don't make inferences about if residue is actually present or not. But for some reason, Dr. Plowman, in my head, we at least at one point talked about if something was seen on the right, but then we don't ever get visualization of the left for whatever reason, we assume it's the same, but then we might have just said, no, don't make inferences. So James Borders, if you could look that up somehow and then.
Yeah, definitely.
That's a really good question.
I think Dr. Langmore had a follow-up question to that, kind of a more specific example. So what if the epiglottis has very little space? So it's very edematous. So in that case, the max is actually not much more than the minimum.
Yeah, so that's a good question too. So we still are going off of their anatomy, even if for some people that puts them at a disposition, right? So if they've got a very edematous epiglottis and the molecular space is more compressed or smaller, we're still, functionally it's that's kind of what they're working with too. And we can't really kind of control for that. And it might mean too that their molecular space is changing over time. And we just kind of admit defeat with that. So we just take their anatomy for where it's at for that exam and try to control for that. And so, I mean, you kind of extend this to, I think head and neck cancer is a pretty clear way to think about it. If someone had, base of tongue resection, let's say, they're going to have a much larger vallecula. And so we are, that might be more favorable for them. And we're going to just judge that larger vallecular space as that larger vallecular space. So there was another point I just wanted to say and I'm forgetting it. Yeah. Yep. So that's what, there's another point I wanted to add to that. But yeah, so we're just doing it all within the context of their anatomy, even if that changes over time.
Mm-hmm. So then, sorry to keep belaboring the point, but then, so Dr. Starmer did bring up an interesting kind of building off of that. She says, so the idea is that if they have very little space, a small percentage of the bolus raises larger concerns than it would if they had more space. Would you say that's correct?
Yeah, exactly. And so It's something to consider. I think you could look at it two different ways. You could look at it, which is the way I think I look at it. It's unfortunately for that patient, they're at a greater risk because of their disposition, because their anatomy. And, as physiologists, we are always taking into account how their anatomy is impacting function. And so I don't think that's necessarily that bad to be thinking about, but it gives us it's a much different way to think about pharyngeal residue than bolus clearance, which I know is certainly done with the original digest. I don't know about digest fees or other methods, but many of the fluoroscopic measures out there, digest fees, and certainly the stuff by Dr. Leonard, bolus clearance ratio and residue ratio, those are all bolus clearance methods, right? And so that gives us different information about swallowing efficiency. And so I think this is thinking about if 10% of the bolus is remaining, we would expect 99% of the bolus to clear, right? But maybe about 1% of the bolus remaining. But if they've got no puriform space or no molecular space, that 1% could result in, airway invasion after the swallow because they don't have this anatomy. And so I think it's not necessarily a bad thing that it's anatomically defined, and it might change person to person. It's something that we are just need to take into account. I think it's, or at least it's one way to take into account. And maybe in the future we try to add bolus clearance methods to supplement that as well. Those are my thoughts.
Perfect. So I think there's another question, but I think you may actually address it in the next slides. Are you planning to talk about the hypopharynx next?
Yep.
Perfect.
Great. Keep the questions coming. I'm, trying. Okay. And I'm loving these questions, and I'm so intimidated that Doctors Plowman, Langmore, and Starmer are here. So hi, everybody. Okay. So the hypopharynx is our next anatomic landmark. So this is using the same 2 points, looking at where the epiglottic folds merge in the epiglottis. We drew our imaginary line. Everything behind it is, the hypopharynx. That's not contained within laryngeal vestibule. And we'll talk about those boundaries in a second. On fees, we often talk about the lateral channels as a kind of a distinctly different entity from the piriforms. And we found it very difficult to actually create a reliable method to say where exactly do the lateral channels start and stop. And also it seemed like some people didn't really feel like they had lateral channels. And so we just call it all the piriforms. And so the piriforms are defined as that three-dimensional space extending from the superior medial-most aspect of the epiglottic folds. So really kind of along that medial edge, superior-most mark, horizontally across to the pharyngeal wall. So it's that kind of three-dimensional U-shape stuff, which may or may not include the lateral channels. It definitely includes the lateral channels, but we're not delineating or differentiating those structures. So how do we rate hypopharyngeal residue? This is the same method as the oropharynx, but just let's bring it down a little bit. So first identify all the residue that we're seeing within the hypopharynx. Then estimate how full would the piriforms be with hypopharyngeal residue. So estimate, just like we did with the oropharynx, try to estimate the piriforms at their largest, which might mean it's during tidal exhalation or when we have the patient phonate. Second, imagine, again, relocating all of that hypopharyngeal residue into that piriform space when it would appear to be at its largest. Again, for liquids, most of the time, this is going to be contained within the piriforms, and for semi-solids or solids, it could be contained kind of higher up on the pharyngeal walls. Provide a number, and then it's the same comment about coding and non-coding. So if it's just two-dimensional coding, we're not seeing any sort of pooling anywhere from greater than 0%, but probably less than or equal to 3%. And then pooling can be any amount ranging from 0 to 100. So if this example here, why don't you all think of a number quickly? So how full are the piriforms with hypopharyngeal residue? And so when you're doing this, what you should be thinking about is assuming normal anatomy, the left will be 50% and the right will be 50%. But what we're doing is when we think about the piriform space, we're summing together both parts and then using that as our 100%. So if for whatever reason, kind of getting back to one of the questions Dr. Langmore asked, if let's say the right piriform was obliterated because of some sort of surgical intervention or radiation edema or something, then it might be disproportionately weighted towards one side as being a larger space. So it's not like we're saying left is always 50%, right is 50%. We're thinking about the space as a whole, summing them together. But for most people, non-head and neck people, most of the time it's split 50-50. So we're looking here, and hopefully we are at like a 1%, 2% range.
Getting lots of 1%. So
perfect.
It's a good
rates. Cool. Here, when I'm looking at this, I'm thinking about two things. So here, what I'm seeing is I see a lot of two-dimensional coding, which again is like that 1 to 3%. And then I see some pooling. So now essentially my eye goes away from the coding because it's such a small amount. And essentially what I'm doing here is just thinking about the three-dimensional pooling, to be honest. And maybe you would add 1 to 2 to your ratings, but that's not going to affect things overall. So if the moment I start to see three-dimensional pooling, even if there's coding, my eyes really kind of go to the pooling instead, and then maybe add 1 to 2 later if you want. So how full are the piriforms with hypopharyngeal residue? So we can kind of, I'll walk you through my thoughts. Essentially what I do, and maybe I'll change my ways, I don't know. But essentially what I do is I look at this residue and I put it over here and I like add it. And then I think how full is that one piriform? And then I divide it in half because this anatomy is normal on both sides. So I'll give you all maybe 10 seconds. Think of your ratings, say them aloud, get practice kind of going out on a limb. Maybe in the chat, type them. And then I'll say my rating and then see what everyone else says from Borders.
While we're waiting, can I just ask one clarifying question?
Sure.
If you have pooling, say 100% pooling on one side, yep. Since we're looking at the maximal area of the structure, you would say 50% overall.
Yep. Right? Exactly. Assuming the anatomy is equal on both sides. So assuming the piriform spaces look to be about equal space sizes on both sides, then yeah, then one piriform, if it's 50% of the piriform, actual piriform spaces, and it's full 100%, then it's 50% of the piriform as a whole is actually filled. So hopefully you all have said your numbers. So in my head, I would move this over here. If I moved it over here, I would think that the whole left piriform would be full, maybe 25%. And because then that's only one piriform and the other side's essentially empty, I divide that by 2 and I get 12.5%-ish. So I would give this 12 to 15%, given some of the coding. What was everyone else saying? I'm curious.
We're seeing a lot of 10%.
Perfect. Okay, could have done 10 as well, but okay, great. So that's awesome, right? So now if I had said 12 or even 15%, we're off by like 5%. Now, of course, what we need to do in the future is look at, do some research where we see what's a clinically meaningful difference and how much does this actually impact reliability and whatnot. But, you know, being off by a few percent, that's not too bad in my book. But maybe I need to heighten my standards. I'm not sure. Okay. I think I've got pretty high standards. I've got pretty high standards, but they're also realistic, but I don't know, whatever. We'll talk about that later. Okay. Then we've got this image here. So how full are the piriforms with hypopharyngeal residue? So I'll let you all give this a try. Maybe try my method, see if that helps you out. So I would maybe move this over here. we've got some of that left over. And we got maybe some of that left over. So we can kind of see, we can see our boundary here. So we got some of that. All right, so I'll give you all maybe 10 more seconds. Okay, so I'll walk you through my thought process. So if I moved this here, I would say that this is a good example of what you just mentioned, Borders. That whole right piriform is full. So that means I'm already up to 50% then. Plus we've got all this post-cricoid, which if I moved it over here, might fill this up about 15, 20%, 10 to 20%, so maybe 15. So yeah, we're probably at like, and then we've got some of this here. So I would say maybe like 60%. I'd give it around 60. I could see more, I could see less a little bit, but probably in that 60 ballpark. What did everyone else say?
Seeing a little bit of a wider range from kind of 50 to 90.
Okay.
A lot falling around about 75.
Okay, yeah, I think, or 70. I think I would argue against 90. I don't think I could buy 90. I could definitely, and I think it's here, I'm thinking this is more two-dimensional coding rather than three-dimensional pooling. We could be off a little bit with that. Same thing with some of this stuff up here. So again, like our eye should really try to be drawn to actual kind of vertical pooling. I think 75 I could totally buy. I think 60 I was being on the lower end, and I think I was just scared to say something higher. I don't know why I'm scared right now. I know why I'm scared right now, but yeah. So I think 75 is probably fine. I would probably be closer to 65 to be honest, but there's a little bit of reliability. This isn't perfect. We're not doing this with image J. We're doing this with our eyes. So there's going to be some variation. And I think we don't want to sweat the small stuff at this point. We just want to try to up our game a little bit. Okay, so then we get to the epiglottis. So this is essentially going to be the boundary for the epiglottis and how we separate the epiglottis from the laryngeal vestibule. So we try to keep this simple. We try to use some similar points now. So we identify the same 2 points where the aryepiglottic folds merge into the epiglottis. We then identify the epiglottic petiole, which is this first bump that we see when we enter the laryngeal vestibule. And what we try to do is locate the trough or the valley or kind of that middlemost point between the epiglottic petiole and that free end or that floppy end of the epiglottis. And then we connect the points. I will say when we get in this region, it's a little bit of like, Hail Mary, like I just hope I can make the leap correctly. And again, we might not be 100% right with the exact pixels that we draw, but at least we're getting much closer to using the same method for clinical purposes. So identify those 2 points, identify the middle of that trough, and then extend the line up to those 2 points. And then everything above that to the point where the laryngeal surface meets the lingual surface of the epiglottis, that would be the laryngeal surface of the epiglottis. So here's kind of another vantage point of that. So we can see kind of the middlemost point here, and then wrapping it up here. And so notably for VASES, we don't consider anything on the epiglottis airway invasion. So this, if we only saw stuff on the epiglottis, this would still be a PIS of 1. We are not calling this penetration. We are not. And I wanted to mention this, maybe I mentioned it at the end. Some of these rules that we created for VASES might not be the most valid. They may change over time. And I think that ideally we stick with it, but I think if you're a clinician or a researcher who has issues with some of the boundaries or the fact that we are saying this is not penetration, that's okay. And I think that you can maybe deviate from it, saying we used VASES, but we included the epiglottis as the first marker for penetration, right? And then the idea is that, well, now even if it's not VASES per se, I know exactly how you rated it. We're going to be reliable, even if we disagree on if that should be how it is or not. So, but anyway, I guess that was a little side tangent. So here, notably, if it's only on here, we are not calling this penetration. And this is to try to be a little bit more consistent with actually video fluoro as well. So how do we rate epiglottic residue? when we get to these structures, the epiglottis, vestibule, vocal folds, and subglottis, we are now switching from filling, where coding really didn't mean much, to now we actually talk about how much of the mucosa is actually covered with residue. So if there's like coating material, it's going to actually impact these structure ratings. So first we identify all the residue that's covering the epiglottis, then estimate the amount of mucosa that's covered with residue. So this should range from 0 to 100 again. Like all of the structures, not just the epiglottis, we may need multiple video frames to actually be able to see the entire structure. Certainly you'll need that with the epiglottis because most of the time it curves, and so you need to kind of get that inferior third or inferior half. And so like all of the other anatomic landmarks, we want to consider the entire structure, whether even if we're not visualizing the entire structure, we should conceptualize how much of that surface area is there, but then we only judge the visualized residue. So this kind of gets at what Dr. Plowman asked earlier. It definitely gets at what Dr. Plowman asked earlier. I just wonder if there was one caveat, which I don't know if we found that yet. So we never guess or make inferences on residue. So you think about non-visualized and visualized surface area, and then only residue that you're seeing that's actually visualized is where we're making our judgments. That might mean that we're missing some residue. Totally understand that, totally get that. And like all scales, it's trying to find that balance of reliability and validity. And that doesn't mean in your evaluation report, you can't make other, impressions or guesses. But for the VASES ratings, we wanted to try to be as objective as possible and not make guesses. So as I mentioned, whereas residue for the oropharynx and hypopharynx landmarks are judged mostly, we're judging mostly kind of the amount of three-dimensional filling. Epiglottis, vestibule, vocal folds, and subglottis are rated by how much the mucosa is actually covered with residue. So illustrated here is the epiglottic landmark with illustrative examples of blue residue that's covering the laryngeal surface of the epiglottis. So here in this top left picture, we have no residue covering the epiglottis. Then we've got these pretend residue circles. And here is a little bit of calibration. This was measured on image J. About 3% of the epiglottis right now is covered with residue. When I measured this the first time, I was like, what, that's 3%? I would have thought that was more. So I think that's kind of interesting. So that's about 3%. I think it might be like 4.2%. Here, about 45% of the epiglottis is covered. And I'll say when we first started training people with this, something that we saw often is that I think what people do oftentimes is think about the spread of the residue, but not thinking about the fact like, oh, there's still lots of mucosa that's not actually covered with those blue circles right now. And so some people originally would skew this rating much higher. And so when I see a pattern like this, where we have a bunch of residue, but then there's like lots of mucosa that's not covered within that parameter, I kind of just like take it in half. Like, oh, I think about 80% of this is covered. Let me cut it in half and call it about 40%. Then I might kind of move it up a little bit or a little bit less, depending on how much of that mucosa I am or am not seeing. And in this example, about 45% of the mucosa is actually covered. This example has the same kind of parameter spread, but now all of it's actually covered. And here about 78% of the epiglottis is covered. So I guess it is about half and maybe a little bit more in this example. So we have 0, 3%, about 45%, and about 78%. Then we get to the laryngeal vestibule. So we extend that line that we just created for the epiglottis around the aryepiglottic folds, arytenoids, and interarytenoid space. So again, we're using the medial most point, that's also the superior most point of the aryepiglottic folds. I think sometimes you could think about like the middle of the top, but we're really talking about that medial surface of the aryepiglottic fold and its topmost point. So kind of going in as much as we can while staying up. And we want to stay along that medial edge the entire time. So we're never kind of trying to go on top. We're always kind of staying at that junction along the medial edge all the way around, which should include this interrytenoid tissue, which typically has a slightly different coloring and a slightly different texture to it, and all the way around. So here's another vantage point. And notably for here, per VASES, we define this as the first point of airway invasion. So once stuff has entered this region, we are calling this penetration. I understand that that might be different than what many clinicians do. This seems like it could potentially be lower down than what's often done in clinical practice. But again, we did this to be more consistent with video fluoro, at least as an attempt. And it's just kind of what we went with. It's just what we went with. There are other reasons, but I'm running out of time. So ask me if you want and email me. Or we could Zoom sometime. I'm down with that. So how do we rate vestibular residue? Identify all the residue that we're seeing on laryngeal vestibule, and then estimate the amount of laryngeal vestibule mucosa that's covered with residue. So how much of the laryngeal vestibule is covered with residue? That should range from 0 to 100. Again, we might need multiple viewpoints. And as I just mentioned, residue in the vestibule, if we're giving it a PIS score, would be a PIS of 2 or 3, depending on if it was ejected or not. So go ahead and provide a rating for this. In your head, how much of the laryngeal vestibule mucosa is covered with residue? It's not necessarily how much of it can you see, mucosa can you see, because some liquids are much more translucent, others are much more opaque. So it's really how much of that mucosa is covered or is contacted with residue. I think it's a pretty small amount. What's everyone saying, James Borders?
They haven't come in yet.
No one's come in yet. Come on.
A little bit of a delay. Cut them some slack.
A little delay. Oh, it's a delay for me.
Yeah.
Got it. Oh, now they're going to start seeing me yelling at them. Okay. So go ahead and provide a rating.
Here we go. 3, 3 to 5.
Love it.
1 to 2, 1 to 3.
Love it. Love it. Love you all. We need more love in this world. I'm so glad the love is here. Yeah, I probably would have said around like a 2 or a 3. I think 5's a little high if I was to be picky. See, I've got high standards. But for like a first stab at things, I'll take 5. And hopefully I can kind of convince you lower. If we said 5, then what we're saying here, if we multiply this by 20, all of the laryngeal vestibule would be full. 20 sounds like a lot, but I still don't think if we multiplied it by 20, all of that mucosa is going to be covered. So I'd probably drop it in half and do like 2.5 or 2. Okay, so here we have another image. I'll kind of walk you through my thought process and have you provide ratings. So when I look at this image, and we haven't actually done this with the image J or anything yet, it's kind of a good idea for a study, I think, is when I look at the laryngeal vestibule, I kind of separate it into 4 areas. I think like this accounts for about 30% of the laryngeal vestibule surface area. I think the petiole is about 30%. I think this is about 30%. I think of the interrytenoid space as about 10%. That's kind of like my own rule of thumb that I developed. That's not necessarily VASES. I could kind of be off with that, but I seem to be reliable with others. So I don't think it's a terrible method. So in my head, when I'm looking at these ratings, I might try to like put all this in one of those sections and see how much of that section is covered and how much of it's remaining. So with all that being said, what would be all of your ratings? I'll give you maybe 10 seconds. So how much of the laryngeal vestibule is covered with residue? All right, Borders, what are they saying? I'm gonna start letting them go first and I'll give my answers afterwards.
Nothing yet. I think it's like a 20-second delay.
Oh, 20-second delay. Okay. I'm gonna have my scone then.
Sure. Someone said 30%, 10%, 75, 25, 15.
Okay. All right, so I'll tell you my thoughts based off of these scores. I'm probably more along that 30% route. This looks like it's like essentially completely coated. This looks like it's essentially completely coated, maybe a little bit less there. But I can move that over here. I see all of this interrytenoid tissue, which I think accounts for 10%, but it's kind of that spread but not completely covered situation. So I see 10, I'd probably divide that in half because we don't have complete coating. So it's maybe another 5, which I think now this area is probably completely full. So maybe that's around 30%. And then we have like this stuff, but that's again kind of spread but not completely coated. So I'd probably divide that in half, and it looks, yeah, I'd probably just divide it in half. So I'd probably be around like the 35% route. I think the person who said 75% and I don't necessarily want to speak for them, but might be kind of looking at that spread, but not necessarily taking into account complete coding, and same thing with all of that. Because I think if we look at all of this spread, that could probably account for about 75%. But I think this is kind of true complete coding for the most part. And then I would half that and half that. So I'd probably say around 35%. Yeah.
Oh, sorry. We had a question from Dr. Langmore that would be, I think would be nice to address. So
Yeah.
Can you speak about the arytenoids? What part of the arytenoids are in the laryngeal vestibule with VASES?
So we would go up along the medial edge, and we would stop the moment we start to kind of go like on any sort of superior surface. So we're containing all of the medial edge as best as we can. So if I was to, let me try to use an annotation feature, if I can figure out how. How do I do? Okay, I can't figure out how to do the annotation feature. Maybe I can if you give me 2 more seconds. I can't figure it out. So if I had to draw it without the annotation feature, I would say probably like.
Oh, can you share your screen again?
Oh, sorry.
When you share your screen, there should be a green thing at the top.
Yeah, but it wasn't. It's like not. I don't know if it's because I'm live streaming. Oh, here we go. And now here. Okay, so does it work on? Oh, perfect. Okay, good. So if I was to kind of outline the arytenoid medial edge, I'd probably do something. I wish I could actually do a different color. I'd probably do like that. And then that. And then everything below that line, oops, sorry. Everything below that would be in the laryngeal vestibule. So again, it's the medial surface up to the very top of that medial surface. And if it feels like we're starting to kind of go on any sort of superior surface, including kind of a curve, then I would not include that as in the laryngeal vestibule. Yeah, so I think maybe maybe I could boost my ratings up a little bit, honestly, now thinking that, because I think I honestly took a little bit less of that into account. So maybe I could boost it up to like 40%. I'm still not sure I could figure out how it could be 75% or even 50%. And I think 10% is probably way too small. So I'm kind of in like a 25 to 40% region. I'm much closer to 30 to 35. And then, holy moly, what do we have here? So I'll let you all provide ratings, 10 seconds, understanding there's a 20-second delay. And so to kind of get again at Dr. Plowman's question, here we're not exactly visualizing much of the interrytenoid tissue. So I still want to take into account the fact that I know there's interrytenoid tissue there. I'm taking that into account into my denominator, even though I'm not visualizing it, but I'm not assuming there's residue there. It's kind of a double standard, but it's at least a double standard that we are transparent about. So we are taking into account the entire surface area, even if not all of it's visualized, and then only looking at the residue that we're seeing.
And then I should also add to that, one thing I looked in the manuscript, we also clarified that you should try to get the best view possible. So if you can visualize it, even if it's slightly later, that's preferred.
Got it. Perfect. All right, so what's everyone saying for these?
Yeah, we're seeing hovering around 70, 80.
Yeah.
Yeah.
Cool, awesome. And so, you know, I think hopefully your people are developing appreciation of why I think this is so important. Again, I think as someone who's worked only in outpatient, in evaluations and tracking changes over time and treatment plans, talking about the fact that this person has 80% of the vestibule covered compared to 5% of it covered, if we just said they had a PAS of 3, we are missing these drastic differences in patients, right? And if this person went from this 80% to that 5%, they're still a 3, but they've really changed and gotten so much better. We can pat ourselves on the back, pat them on the back first because this patient-centered care, but still. So hopefully I think we can all agree the value of kind of quantifying this. And of course, there's other skills that have previously done that, but really trying to push for that. Okay, so then this brings us to the vocal folds now. 2 more landmarks to get through. All right, so all right, so we've got the vocal folds. We've got the vocal folds, everybody. And what we've defined as the boundary for the vocal fold for VASES includes the laryngeal ventricles. So that's the space that's contained between the vocal folds and then the ventricular folds, or what we also call the false vocal folds sometimes. And so sometimes we see those in patients, sometimes we don't, but it's the space that's kind of tucked away between the ventricular fold or false vocal fold and the vocal folds themselves. So that's one aspect of it. It's the space that we see right here. The boundaries for the vocal folds also includes the superior surface of the membranous vocal fold. So the membranous portion of the vocal folds, by way of review for anatomy, extends from the anterior commissure to the vocal fold processes. Okay, so it's the vibrating portion of the vocal folds. This is where maybe my voice is influencing some of this stuff. We also have the medial edge of the vocal folds, which I think as clinicians, we oftentimes forget about. We think of the vocal folds. I feel like we oftentimes think of the vocal folds as very kind of 2-dimensional sheets that are moving back and forth, but they've got a decent amount of actual height to them, of vertical level to them, or medial edge. And so the boundaries for the vocal folds includes the medial edge of the vocal folds too, not just the superior surface. So first we identify, I should say too. So essentially what we're doing is we're identifying the inferior most point of that medial edge and then extending that along the left and right vocal folds. It could get a little hairy in this territory. So what I tend to do is I look at the edge, and then I might have to make a prediction of where those two would converge. But typically you can get a pretty good image. So all of these points together make up the boundary for the vocal folds. So in order to judge vocal fold residue, first identify all the residue that's on the vocal folds, then estimate the amount of vocal fold mucosa that's covered with residue relative to that superior surface of the membranous vocal folds. And I do have to say, I'm not sure we actually specify superior surface of membranous vocal folds in the original manuscript. I just got reminded that I should probably try to write the editors or something, but superior surface of the membranous vocal folds is how we are doing this. And then provide a rating ranging from 0 to 100%. And so notably residue on the vocal folds, but that's not crossing that lowest most boundary, would be considered a penetration of 4 or 5, meaning that there is penetration to the level of the vocal folds, but it hasn't actually gone to aspiration. And so that means, and this is definitely going out on a limb, I understand that, and happy to talk, and happy to dodge bullets, is that because these are the vocal folds, this residue that we're seeing in this image here, most of it would still be considered penetration. I think you could argue that a little bit of this here is actually crossing that boundary. And so if I said there was aspiration in this picture, it's because I'm really only judging that little shadow right there and not this, because that's the lowest boundary of the medial edge of the vocal folds. It's probably one of the most controversial things I get when I give in services on this. But hopefully it kind of makes sense. When we think about video fluoroscopy, we kind of have that dark band that we use, which is very much three-dimensional as the vocal folds. When we think about it from an anatomic standpoint, we think about sensory innervation of the vocal folds, and it's not just the superior surface, it's the entire length of the vocal folds. So when we think about physiologically in terms of airway closure, I think this makes sense. So I'm happy to have this discussion with others. It's something I feel pretty passionate about, but for VASES, this is what we do. So I'm going to try to move this along a little bit quicker. So here would be an example of maybe about 3% of the vocal fold being covered. Here, we have a lot more residue. I think the challenging thing with this image is actually identifying the boundary. And this might happen sometimes. VASES isn't necessarily foolproof. And so we know how to draw the boundary, but literally what are we looking at in this image is a slightly different question. And so I think if we thought this was the inferior most boundary, and this is the superior surface, I could see about maybe 70% of the vocal fold being covered here. Maybe a little bit more because we'd be including this. So yeah, I would say the entire right vocal fold is covered, maybe like 75, 80% of the vocal fold residue in this image. Here, we're not making inferences about what we're missing in terms of medial edge. So we're just judging what we see in this image. This is kind of a weird image, but probably around 90% of the vocal folds are covered here with residue. And then we get to our last anatomic landmark, the subglottis. So by way of review, we have the subglottic shelf, which is that kind of triangle that's from just beyond the inferior most border of the medial edge of the vocal folds to that first ridge that we see in the subglottis. So that's the subglottic shelf. And I think most people would agree with these terms and these anatomic definitions. Maybe not everybody, but I think most people would. That first ridge is typically considered to be the cricoid cartilage. And then everything below that would be the trachea. So these are the boundaries or the for the subglottis, right? So essentially everything below actually crossing that inferior most boundary. And so for VASES, what we do for every anatomic landmark is, and this is consistent, I think, actually with Dr. Steele's aspect method, is that it has to actually be crossing that boundary, not just on it, for it to be considered having entered that region. So if it's on that inferior most border of the vocal folds, but it doesn't appear to actually be visibly crossing, then it would just be vocal fold residue. The moment it crosses that border is when we say it's now entered the subglottis. Same thing with vestibule to vocal folds, or epiglottis to vestibule, or oropharynx to hypopharynx. So here's another vantage point. And so here's where we would get our PASs of 6, 7, or 8, or estimated amount of aspiration. Of course, we could certainly be missing it, but an estimation nonetheless. So to do this rating, first identify all the residue that we're seeing in the subglottis. Sometimes we get really good views of the trachea, other times not. So we take into account everything that we're seeing in the subglottis, including the shelf, the cricoid, and the trachea. And then we estimate the amount of mucosa that would cover specifically the subglottic shelf. So if we see stuff in the trachea, it's going to be kind of like the oropharynx and hypopharynx. We're going to pretend to scoop it up into the subglottic shelf and then estimate how much of that subglottic shelf is covered with subglottic residue. So this ranges from 0 to 100. And so this would be a kind of a fictitious example. So if we have residue in the subglottic shelf, and let's say in the trachea, highlighted here in these weird yellow shapes, what we would do is move that residue that we're seeing elsewhere in the subglottis into the subglottic shelf, and then estimate how much of that subglottic shelf is actually covered with residue, including the visualized subglottic shelf surface area and the non-visualized surface area. So in this example, this would be about 25% as measured with image J. Oops. So in this example, we get here again, our aspiration amount, or the amount of subglottic residue rating that we would see. I could see 0%, or I could maybe buy that this looks like it's crossing over and not actually just on the border, in which case I would say something like 1%. Because I'm not really including all of that. That's all vocal fold residue. In this example, I'm looking at this white band, how much of that subglottic shelf is covered with this. So you all provide ratings. We've got a couple more images and then we are essentially wrapping up. A few more slides after that and we'll be done. So how much residue is covering the subglottic shelf surface area? And borders if you've got some.
Nothing yet, but.
Okay. I turned off my AC for all of you and very much hot in here, just FYI. But you don't have to thank me for that. That would be weird. Okay, what?
Yeah, 2 that just came in. Let's see, a 3.
Love it.
1%, 1 to 2, 3. Perfect.
Love it. Great. Yeah. So a very small amount, right? What's cool about this is, well, actually, I'll talk about that later. Okay. So here now we're trying to actually quantify or estimate the amount of aspiration being present, which I think is a pretty cool outcome. Here, what we're looking at is we've got some residue on the cricoid, we've got some residue in the trachea. We'd move it all into this region here, along with this. And then I would say, okay, you know, that's about half of the subglottis. I move this here, it's covering up that. We've still got some here that's not covered and maybe some here that's not covered. So I would give this maybe like a 40%. I could maybe see 50. I was being sloppy and fast in clinical practice. But if I gave this an extra 5 seconds to look at, I'd probably say around 40%. So this person had 40% subglottic residue. This person had about 5% subglottic residue, or 2 or 3%. And so now, rather than saying, oh, this person had a trace amount of aspiration or a gross amount of aspiration, we're being a little bit more kind of zoned in, which I think is probably going to be a good thing for clinical practice. And then this would be an example of probably around, 90, 80%. We see a lot of it is completely coated. We get some of that. We're still seeing some mucosa kind of peep out. So that's a summary of our anatomic landmarks. And so now I just want to end with how we would integrate this into clinical practice, just for all the clinicians out there. So first thing I would do is I would indicate that in your report writing, you're using VASES as the basis for your interpretation. So we all are on the same page, right? So I know when you are giving these ratings that, oh, they're using VASES, so this is how they're drawing this landmark, this landmark, this landmark, this is how they're doing these temporal boundaries. Then you as the clinician or your team need to figure out when are you going to provide ratings for pharyngeal residue penetration and aspiration using VASES? So are you going to use VASES for every single swallow, or are you going to use it for only certain swallows? I think ideally you rate every single swallow. That's part of your standardized fees protocol. That I think would be ideal. But you know, when I was working at UCSF, one of the things we started to do with video fluoros was integrate kinematic analyses using the methods by Dr. Leonard and Kendall. And what we did there was we just started off with, you know, one swallow at a time and certain measures at a time. And so something you might do in clinical practice is say, you know what, I'm just going to start off with rating the first swallow of the different swallowing conditions that I'm doing. So when I say swallowing condition, I'm talking about different bolus volumes, different bolus consistencies, maybe different instructions, like it's a held swallow or acute swallow. Or maybe you say, I'm going to rate all of the swallows of a certain condition. Like I'm going to rate all of the patient preferred volumes of thin liquid via cup, or all of the 20 ml single swallows of water via cup, right? So maybe you start small and kind of slowly build yourself up over time as you get faster and can manage it with clinical practice. So once you determine which swallows you're going to rate, view the bolus of interest. We should be doing that anyways if we're billing for fees. And then rate the 7 different outcome measures. And what we found with graduate students is this takes about 1 minute to do. So, you know, that can build up over time, and you'll probably get faster over time as well, given some of the research by Dr. Anna Miles with swallowing kinematics. But it takes about 1 minute to do. So I think that if you're being selective about which swallows you're doing, totally feasible to integrate into clinical practice. And I think it's probably feasible to do all swallows. So this would be an example of me reviewing a video clip. Here I'm giving them green opaque water. So there's water that I dyed with white dye and green dye.
And then lift your chin up.
This would then be kind of between the bolus trial, then getting a view of everything.
Can you turn your head to the left? Good. Say E. Good. Hold it up for 10 seconds. E for 10 seconds. There we go. And just breathe. All right, back to neutral position. You can.
Okay. So then I would go over to my rating form or my Microsoft Word or my electronic medical record or my paper sheet, whatever I have that I'm using to just document fees interpretation in general. On a sheet that I would use, I would probably document the colorant that we've used, the consistency, the bolus volume, if there were specific instructions like do this in a single swallow or do it naturally or do it when I tell you to swallow. I would document all of that because all of that can impact functional swallowing outcomes, and then provide our ratings. These last 2 measures are not measures that are part of VASES, but I think we could probably do anyway. And so that video was not long. That video was like 1.5 minutes, and that includes the viewing time then too. And then you have your ratings and do with them as you will. So you use them to characterize residue, penetration, aspiration by swallowing condition, using either maybe the maximum score like MBSIMP does, or taking the average or looking at variability. There's currently no standard in terms of how we are currently using these measures in clinical practice, but hopefully we become standardized with that over time. But, you know, if I was a clinician, I would probably start off by, if I did maybe 3 trials of patient preferred volumes of water, I would probably just rate those 3 trials first and then take averages of that or something like that for each anatomic landmark. And then over time, include another condition and another condition so I can get faster and faster over time. So in conclusion, VASES, it's a standardized rating methodology used to increase the transparency, standardization, reliability, and generalizability of fees. It's a framework. It might not be perfect for every patient, and I think that's okay. And I think that, you know, maybe still use it as a foundation and then make adjustments. But if you make adjustments because the patient is very unique, then just be specific about how you've made the adjustments so others can replicate your interpretation as well. And we expect there maybe to kind of be reiterations over time and it to evolve over time, kind of like digest. I think it's brilliant. I think it's a strength for it to be kind of flexible. So that's VASES. And if you want to learn more about VASES interpretation, just as a little bit of a plug, we had a presentation or a 1-hour seminar at this year's ASHA. Dr. Susan Langmore, who it sounds like she was here at one point, she may still be here, and Heather Starmer at Stanford University, who helped to develop digest fees, will be presenting together to talk about VASES and digest fees. So I encourage you to check it out if you're coming to ASHA this year. And I'd like to thank you again for all of your attention. Hope you all learned a lot. We'll post this recording to our websites, and I'm happy to take any questions right now for a couple of minutes. I don't know if Borders has to leave, but maybe we can stick around for 2 or 3 minutes.
Definitely. One question that's come up a few times that I think you alluded to a little bit when you were speaking about the numerical ratings study that's under review, but a few people have asked if VASES has been validated and if you can kind of speak to that.
Yeah, I can speak to that. I feel weird speaking to that because it's under review right now, but we submitted a follow-up study to look at the validity of VASES. There's different ways you can look at validity, and what we did is we compared it to other validated fees rating scales, and we compared ratings, did some stats, and looked to see if it was valid. They're promising, and we saw good things. So I think you can feel pretty good about it. I just don't know what all I can say because it's under review right now, but it's pretty good. We'll make an announcement on Twitter when and if it gets published, but I would think it's okay to use VASES.
Another question that came up was in terms of rating secretions. Do you think that VASES is something that should be used to rate secretions, or?
Yeah, I think that, okay, so I'll speak as a researcher and then also as a clinician. So as a researcher, we haven't validated it for secretions yet. And so as like a scientist and someone who helped to develop VASES, I would say we didn't look at it, so who knows? As a clinician, if I was seeing someone with secretions, I don't know why I wouldn't adapt VASES for it. It's not necessarily, we won't know the implications of certain things because there haven't been studies that have like compared VASES ratings of secretions to other things, but you've got anatomic boundaries, you've got temporal boundaries, there's a anatomically defined method to rate these secretions. So I don't know why you wouldn't necessarily, if you're seeing lots of secretions, why you couldn't say 20% of the pure forms are filled with hypopharyngeal secretions, which cleared after the swallow or something like that. I don't know why you wouldn't be able to, but it's not something that we looked at or specifically validated. So, so I like to hedge a lot, as I think you've all been able to tell. But yeah, so if I was a clinician, I might, because I really kind of go off of theory and things that kind of make sense to me. But yeah. But we also didn't look at it. So I don't know. Borders, what are your thoughts? Can I put you under fire for a second? What are your thoughts?
Yeah, I think that, for now I may, until we kind of adapt it, stick to some of the validated secretion scales. But like you said, as a clinician, we got to hedge, right?
Yeah.
But I think it's something definitely for future work.
Yeah.
And for clinicians, if you want to adapt it, we'd love to hear kind of how that maps on in your clinical experience when you take this.
All right. I need to take notes on how to respond to questions from James Borders. He's pretty solid. Okay. All right. Other questions?
There was one question about kind of clinical implementation. So would you recommend kind of integrating this into your actual, the chart, or just use the Excel spreadsheet like you showed us? Kind of what are your recommendations for that clinical implementation?
Yeah. So that Excel spreadsheet is very much unofficial, was not part of anything. It's because I've been giving in-services and I just created something on the spot for one of the in-services that I was giving. And I figured, why not upload it to my website for other clinicians? I think it really is just depend on your flow in clinical practice. So if you have templates that you've created that are that you can modify, I would do that. I might have a template where it's by swallow condition, you have your VASES outcome. So yeah, I'd probably create some sort of template. I probably, if I was a clinician, probably wouldn't be Excel. It'd be integrated into Epic somehow. So it's part of an evaluation report that's right there. That's how I would do it. And then I would do something where it like auto calculates the average based off of each swallowing condition, maybe also a max for each swallowing condition. But by condition, I would probably have, and by swallow, I would have the different ratings. Yeah.
Yeah, and I think I'll add to that if your hospital or clinic is able to have a visual analog scale that's implemented directly, integrated into the chart, then that's definitely a plus. But hopefully we'll have some research soon that shows that you can use numerical ratings.
Right, yep, exactly.
Perfect. Well, those are all the questions that came in. A lot of people saying they're going to start using it tomorrow, so that is only a plus.
Right. And my advice is, like I said, don't get stuck in the weeds. Don't get frustrated if you're off by 5%, 10% from another colleague or friend. Really kind of spend the time to calibrate with yourselves, practice with each other. I think read the manuscript to really look at temporal boundaries. That's probably one of the more challenging things, but it's something to kind of grow, and you'll get better over time and you get faster over time. So, think bigger picture. Don't worry about if you're off by a couple of frames or something. Yeah. So, and start small, start off with a couple of boluses and then work your way up over time, so you're not completely inundated.